Okay, we're going to start back today with part 2 of the lecture on chapter 8. We're going to pick up on page 179 with lower respiratory diseases. So, I'm going to start off on PowerPoint slide 97. We're going to talk about COPD, otherwise known as chronic obstructive pulmonary disorder. We'll talk about bronchitis, acute and chronic bronchitis, asthma, emphysema, pneumonia, pleurisy, pulmonary tuberculosis, cancer, and cystic fibrosis. So let's start our look with the COPD, which is chronic obstructive pulmonary disorder. This is also called cold chronic obstructive lung disease, and it includes a variety of diseases like emphysema, bronchitis, things of that nature. So this is when the exchange of respiratory gases is ineffective, and it includes chronic bronchitis, emphysema, and chronic asthma. If you look on the next slide, you have a little video on the topic of pulmonary disease. And then let's go on to bronchitis. Bronchitis is inflammation of the bronchi, and this can be acute or chronic. Acute is short-term, chronic is long-term, usually due to smoking, secondary exposure to secondhand smoke, environmental factors, and things of that nature. So what happens in the bronchus, we usually, in the bronchioles, those usually are lined with mucous membranes, and when these mucous membranes are irritated in some way, and they contain bacteria, they become very swollen and infected and cause bronchitis. So this can happen from environmental factors like fumes, exhaust. Then of course you have viruses, bacteria, and things of that nature. And you can even have a fungal cause that causes acute bronchitis. Bronchitis is generally more serious in children, small children, and the elderly because they are the ones with the weakest immune system. Tiny bronchioles of children become easily obstructed, and that can lead to pneumonia and things of that nature. Symptoms of bronchitis are chest pains, dyspnea, which is painful respirations, cough, of course, fever, and sometimes even chills with a fever. The sputum that you cough up, usually it is productive, and sometimes we may start out feeling with a chest tightness, and because it's combined with a bunch of purulent stuff in the chest that may not be coming up, and then we can give a patient something warm to drink or an expectorant, which is a type of classification of medicine that will make the congestion loosen up and come up. So when the sputum is coughed up, it can be green, it contain pus, it may contain purulent discharge such as pus and things like that. Depending on whatever type of organism is causing bronchitis, we can use antibiotics for bacterial infections mainly. Viruses really do not respond to antibiotics. They may, make the patient feel better, so we usually give a viral bronchitis patient something like steroids or other medicines to improve their symptoms. And then we go on to chronic bronchitis. This is repeated attacks of acute bronchitis, and so this is also chronic coughing up sputum. It can last from 3 months to 2 years, and sometimes happen all of your life as well, but symptoms are persistent. And I believe it can also run in families as well. It can be a complication from another respiratory infection, or it can be a result to long-term exposure, like I said, to environmental factors, smoke, things of that nature. And this is more common in men than in women. So symptoms of bronchitis, of chronic bronchitis, you're going to have excessive secretions of mucus. The mucus glands, basically hypertrophy in the mucosa, is thickened and inflamed, and this causes a chronic cough, chronic mucus in the chest, and chest congestion. And it may even interfere with oxygen level. Hypoxia is another symptom. This is an insufficient supply of oxygen to the tissues. And poor drainage in the mucus sets the stage for, of course, bacterial infections, and this can make your chronic bronchitis a lot worse than setting an acute infection. And when this happens, you can also have a necrotic part of your bronchial tubes, which means it necrotizes or ulcerates and dies. And then you can have scarring on the lungs, and so that can be pretty dangerous. Symptoms can be treated with antibiotics, especially if it gets to be an acute infection. Moist vapors are usually good to use. Cigarette smokers should obviously quit. If you are in an environment where you're being exposed to fuel or different gases, then you probably need to reconsider being in that environment. Okay, let's look at bronchial asthma at the bottom of page 180. This is hypersensitivity to different allergens. It could be dust, ragweed, pollen, pet dander. It just depends. 80% of kids with asthma and 50% of adults with asthma have allergies, and it's usually caused by allergies. Asthma is usually caused by allergies. So what happens, the allergy comes in, it constricts the airways and causes an asthma type effect. It narrows the lumens of the bronchioles, and we start having bronchial spasms, and it's hard to breathe when that happens. This also makes the mucous membranes in the bronchioles and the bronchus very swollen. The mucous membranes may dry out completely, and it narrows the lumen. So also, if you have a bronchial tube that is dried out, or it may even have excessive mucus secretion, that can lead to an obstruction. And then basically what happens is you have stale air that's sitting around, it's not being exchanged, it becomes trapped, and it decreases the amount of fresh air that can enter the lungs, and that can harbor infection. One of the main signs of bronchial asthma is wheezing, and what happens is this is when air you're inhaling like you usually do, and air becomes trapped, and it has a little bitty space to come through, and it makes that wheezing sound. Let's see. Some things that can trigger bronchial asthma attacks is like a stressful situation or where you may be emotionally unstable. That can trigger it as well. Overexertion, of course, when you exercise. If you have any type of other infection, or if you have bronchitis, all of those can trigger bronchial asthma. And then being exposed to environmental factors like certain perfumes, certain cigarette smoking, certain gas or fumes from the gas, or fumes from anything can make bronchial asthma flare up. So there is no cure for asthma, but they can become less severe if you take daily medicine for it. And you need to figure out what allergens trigger your asthma attacks. So that's what bronchial asthma is. Let's look at figure 8.6, and you can see here at the very top we have a normal bronchiole, and you can see the mucous membrane. And then with an asthma attack, look, it becomes all constricted, and then your mucous membranes and your muscles constrict, and you have tons of mucus in there, and you can't breathe. And so that's what happens during an asthma attack. If you look at figure 8.7, this is a spirometer that they use for some patients that are bedridden while they're in the hospital to keep their lungs functioning. Figure 8.8 shows a nebulizer in the A, and then B shows like a meter dose inhaler or a respiratory inhaler that's used. So let's talk about the treatment and prognosis of asthma. Allergy shots are the common medicine that we use, and again, like I told you in the first part of the lecture, allergy shots are actually small, minute amounts of allergens that are in the medication or mixed with a serum that helps you become less sensitive to the allergen. So other medication you may get is things some type of breathing treatments daily. You may have things like Advair or albuterol inhaler, different meter dose inhalers that may be used. You may also have steroid medications as well. One thing that we can give for patients that are having like an acute flare-up of asthma is we can give them epinephrine, which is also known as adrenaline. And of course this loosens that constriction and helps you to be able to breathe better, and it basically, is pretty effective for that. Bronchodilators like albuterol and metopropanol, that should be what that is, are usually prescribed. Cortisone, which is your steroid drugs, antihistamines like Benadryl can be used as well. Steroids, of course, have a lot of side effects. Antihistamines usually cause drowsiness, so we try not to give those if we can absolutely help it. So the most severe form of the asthma attack is called status asthmaticus, and this basically happens when the patient fails to respond to the usual treatment. Sometimes the doctor may have to do a tracheotomy, which basically they slice open the throat to expose the trachea to get air into the throat. And if we can't do that, then usually the patient will die from that. We've actually had a student here at the college that she was having an asthma attack and she had status asthmaticus, or I thought she was having it, and I was trying to pry her mouth open to get her to breathe, and finally she breathed, but I thought that we were going to have to, that she was going to die. So that was a pretty scary situation. Asthma kills at least 15 people daily in the United States, according to the Lung Association. So that's pretty big numbers for asthma. Let's see. Let's go on to emphysema on page 183. Emphysema is a type of chronic obstructive pulmonary disorder, and it's a crippling and debilitating disease with chronic lung obstruction and destruction. So basically it weakens the lungs, and usually this comes in stages and can cause death eventually. So the word emphysema means inflation. The lungs become filled with air that's high in carbon dioxide, so you're not having a good oxygen-carbon dioxide exchange. The air can't be exhaled very well to allow oxygen to re-enter the lungs, and so the patient may feel like a suffocating feeling, not able to get that air exchange going on. This can also cause extreme pressure on the lungs. The patient even may have chest pain as well. The cause of emphysema is not known. They think that smoking and exposure to environmental factors and allergens can cause emphysema as well. An inherited form actually does exist too. It's called alpha-1 antitrypsin, and this happens if it is hereditary or inherited. This can cause alveolar damage, and so it's a little bit more severe. Emphysema is usually a complication from chronic bronchitis that happens later on in life, but whatever way or whatever causes it, which we can't speculate, but we don't know for sure, the alveoli kind of break down because the walls weaken and they break down. Then they'll start fusing together, and the lungs are not. They lose their elasticity to breathe in and out, and they can't expand as much. And so again, you have that bad exchange of carbon dioxide and oxygen, and the patient feels like they're suffocating. Signs and symptoms of emphysema: we're going to have an increased breathing rate, and it may be short, loud breaths instead of long, deep breaths. They may have a greater than normal expansion of the chest, and we call this a barrel chest. When somebody has a large chest, they may have, that's called a barrel chest, and it could be from increased breathing like that. Hyperventilation can happen. Let's see, permanent expansion of the chest, which I already said, which is the barrel chest. Abnormal respiratory sounds called rales can happen. Lungs may even go to right-sided heart failure or cyanosis because of the hypoxemia. And then if we have hypoventilation, this reduces oxygenation of the blood. So emphysema is a chronic disease that can last for a lot of years, and it has irreversible damage to the lungs. And it can also cause problems with other parts of the body, such as the heart, mainly. It can lead to an obstruction primarily of the pulmonary artery, and this can cause fluid around the heart and lungs. It can cause fluid in the extremities as well, and it can cause the lungs to collapse. So if you look at figure 8-9, this shows you a male patient that has emphysema. So you can see they have that barrel chest, and you can see their mouth is usually open. They look very tired all the time because they're stressing trying to breathe. And then here's another one, a video on the topic of emphysema, which is your slide 132. Let's go on and talk about diagnostics. For emphysema, we can do a spirometer, which is a breathing test, measures the movement of air coming in the lungs and going out of the lungs. X-rays, they don't really show us emphysema in the early stages, but it can show in the later stages. Treatment involves eliminating the source of the irritation. A smoker, obviously, you're going to stop smoking, avoid polluted air, avoid fumes, irritating dust, ozone warnings. You should not go outside if the ozone is a particular way. Outdoor activity, when the ozone level is really high, you should avoid that. Medications, we can use like some decongestants, some steroids, any kind of nebulizer treatments and things of that nature. And usually we have to do breathing physical therapy or occupational therapy for the patient to get them to start breathing well. Let's go on to cystic fibrosis on page 184. Cystic fibrosis is a disease that affects the exocrine glands. Instead of the endocrine, it's the exocrine glands. And these are the glands of external secretion. So these secrete mucus, perspiration, and digestive enzymes. So somebody that has cystic fibrosis is going to excrete tons of this instead of just a little bit to function properly with. So this is a hereditary disease that they usually find out before the patient is born. It usually starts affecting young children, and it's transmitted through a recessive gene that's carried by each parent. The mortality rate before we kind of knew more about cystic fibrosis was extremely high, but now we can pretty much control it, and they can lead a pretty good life. The trachea and bronchi secrete very thick mucus, and it accumulates, and the patient can't breathe, and then they have to have suctioning a lot as well. So symptoms of this are going to be wheezing, persistent cough, very thick sputum, difficulty breathing. They're going to be more susceptible to respiratory conditions because of that. With cystic fibrosis, the bacteria tends to kind of stick to the mucus more instead of the mucus helping rid the bacteria. It'll stick and cause all those bronchial infections. Let's see. Some side effects or some adverse reactions that can happen with cystic fibrosis is lung collapse, because the secretions may be so much that the lung can't control it and it will collapse. Death from respiratory failure can also happen. Let's see. Sweating is obviously one. The patient will excessively sweat, lose large amounts of salt from their body, and so these patients are going to be more at risk for heat exhaustion, sunstroke, things of that nature. So to diagnose cystic fibrosis, is it's called a salt test, basically, to see how much is excreted, how much salt is excreted from the body. If you look on slide 144, you can see a video on the topic of cystic fibrosis. And then table 8.2 is really good. It's complications of cystic fibrosis. So you have malnutrition, dyspnea or lung collapse, recurrent respiratory infections, and then of course electrolyte imbalance, where that salt comes into play. So let's go on to pneumonia on page 185. Pneumonia is quite common, and it's an acute inflammation of the lungs in which the air spaces in the lungs become filled with an exudate, which is like a mucousy, scabbing type of product. Oxygen exchange is of course going to be impaired. It's going to cause difficulty breathing and very painful breathing in a lot of cases. So other symptoms, we're going to have pretty high fever, chest pain, productive cough. Productive cough can be pretty bad. To diagnose it, we'll do a chest x-ray. We may even do a sputum analysis to see what kind of bacteria it is that's causing the pneumonia. Let's see. Let's look at lobar pneumonia. This is like, it can be either in the left lobe or the right lobe. So this is inflammation of a section of the lung. It's most often caused by the pneumococcus or streptococcus, okay, when we have lobular pneumonia. Let's see. People that have chronic bronchitis, weakened immune systems, are going to be more susceptible to pneumonia, lobular pneumonia anyway. Treatment for this is antibiotics like penicillin, and any kind of penicillin will work really good. And then of course lots of bed rest as well. Then let's look at bronchopneumonia. This is obstruction of the small bronchi in the lungs, and usually what happens with bronchopneumonia is very painful, and it's usually due, also called aspirative pneumonia, because it's when you aspirate some kind of gastric juices. You may aspirate vomit sometimes into the lungs, and that can cause what's known as bronchopneumonia. And basically it shows on x-ray, it shows a lot of information in the lungs. So other things that can cause bronchopneumonia is chronic bronchitis, measles or the whooping cough, bronchiectasis, old age, and cancer can all cause bronchopneumonia. Now let's go on to primary atypical pneumonia. This can be caused by a variety of microbes. Mycoplasma pneumonia is the main one. Interstitial pneumonia, commonly a viral infection, and it has a very certain type of pattern on an x-ray. And this is pneumonia, the interstitial is going to kind of be in between the ribs. That's where that happens. This happens more in teens and people in their 20s. Legionnaire's disease. If you'll look on that page 187, you've probably heard of this before. But this is a bacteria called the Legionella pneumophilia. And what happened, there was a lot of people at the American Legion that all of a sudden became very sick. And they found that's how they got this disease. So this is characterized by flu-like symptoms, and that's what makes it kind of set apart from pneumonia. It's a serious and pretty fatal disease. To diagnose it, we need to do x-ray and sputum culture, and to kind of differentiate it from pneumonia. A lot of people may think it's just pneumonia. This is spread by droplet inhalation, so pretty contagious. Erythromycin is a good treatment for it. That's the treatment of choice. And let's go on to secondary pneumonia. Secondary pneumonia is another type of pneumonia that can develop from a primary condition. So Graft recipients, skin graft, and immunocompromised patients like HIV and AIDS, these are going to be the ones that are going to have this secondary pneumonia, and it can be caused from fungus like the Pneumocystis carinii and Cryptococcus neoformans are both common fungal infections that cause the fungal type of pneumonia. Postoperative patients are common for this. Bedridden patients are common. Chronic respiratory illness patients, people that can't clear their lungs effectively, are going to develop pneumonia. Influenza or the flu can cause pneumonia. This secondary pneumonia, so it can be very deadly, and so we want to try to. There is no treatment really for the flu, but we want to try to, stay well with it so we don't develop a secondary pneumonia. And let's go on to pleurisy at the bottom of page 187. This is the inflammation of the pleural membranes that surround the lungs. This can happen by itself. It can be, it can accompany other diseases like any kind of lung condition, pneumonia, tuberculosis, and it's very, very painful. You have a sharp stabbing pain with each inspiration, so it can be from excessive or insufficient pleural fluid, or you may have pus or blood in the lungs as well. The treatment is antibiotics. You can apply heat and bed rest, but it is very miserable to have. And let's go on to pulmonary tuberculosis on 187. This is a chronic tuberculosis, and it's an infectious disease characterized by necrosis of the lung tissue, which is death of the lung tissue. This is very common respiratory condition. It can affect other systems as well in the body, so we have to be very careful and try to catch this as early as we can. The main cause for primary tuberculosis is bacteria called the Mycobacterium tuberculosis. This is usually transmitted from contaminated sputum, and the sputum air droplets can travel and settle in places, and that's how other people can pick it up. Let's see. Let's talk about the pathogenesis of primary tuberculosis, and I'm on slide 164. What happens is when you inhale the bacteria, it infects the lungs and induces a chronic inflammatory response that leads to the tissue death of the lungs. So the tissue will become really soft and very cheese-like, and what happens is after that the tissue heals, but it calcifies, so it can no longer really function. And these little lesions that are left on the lungs from these calcified lungs are called tubercles, and so that's how you spot them with tuberculosis. Usually when it first starts, you're not going to have any symptoms with this. Sometimes you may get more infections while you have this. Just thinking, you may just be extra sick this time of year or whatever, but this can happen at the onset of this. When the bacteria kind of come off of the walls of those tubercles, they spread their way into other organs, and then it becomes pretty bad. The patient will have infection, malnutrition, or it could be caused from immunodeficiency as well. So during that part, leukocytes will recognize the bacteria as harmful, and they'll mount an attack that leads to even greater death of the tissue and destruction of the tissue. So it's a pretty bad condition. So when that happens, we start coughing up blood, we start coughing up tissue, bacteria may be coming up with it. Then when we start coughing up, it can spread to other organs. Brain, kidney is the most common. Bones can be very common. Let's see, at this point people will become cachetic, or cachetic, which means that they start losing weight. They look very thin and frail, and so it just basically consumes their body. And then the treatment and screening for tuberculosis on the next slide. The treatment involves antibiotics for the Mycobacterium species, and then we also do anti-tuberculosis, or basically anti-tuberculosis antibiotics as well. Rifampin is the most common one. Let's see, you can take it you may even have to take it like up to 18 months at a time, and these do have pretty bad side effects, but we want to make sure that the bacteria are totally gone. Screening, of course, we can do the Mento skin test, where you inject a little bit of serum. It's called PPD, purified protein derivative, under the skin. Make a wheel, and you read it in 48 to 72 hours to see if the patient has been exposed to it. If it's positive, that doesn't mean that they have it. It means that they've been exposed to it, and they have to receive a chest x-ray to confirm. Tuberculosis is pretty uncommon, except, where there's maybe very poor people, poor hygiene, people with HIV and AIDS, but it has increased since the 80s and 90s because AIDS and HIV has increased. The next slide is a video. Let's see. We're going to go on to pulmonary distress on page 188. I'm just going to touch on a pneumothorax. That's what I really want to talk about. This is called air in the chest. That's what pneumo means, air. Thorax is the chest. So this involves the accumulation of air that escapes its normal entrapment within the lung, and it gets outside of the lung into the chest wall. This usually happens from a stab or a gunshot wound to the chest. What happens, the pressure in the intrapleural will start expanding, and it exceeds the capacity, and then the lung collapses because of that, and it's called atelectasis. Let's see. It occurs most commonly with newborns that have a stiff or inflexible lung, resulting from IRDS, which is respiratory distress syndrome in infants. Ventilators can cause this. CPAP machines can cause this. So there is more things, but commonly it does happen from some type of trauma. You may also have ARDS, which is adult respiratory distress syndrome. This can develop due to aspiration or inhalation of food or vomit material into the respiratory pathway, and it causes ARDS. Then we have bronchogenic carcinoma, which is the most common type of lung cancer. Causes 28% of all lung cancers, of lung cancer deaths, basically. So basically, bronchogenic carcinoma means that the cancer actually started in the lungs. So it didn't metastasize to the lungs. It actually started in the lungs. What we have with bronchogenic carcinoma is you have a danger of airway obstruction. Death can result from complications because of that. And then, of course, you can die because of the effects from the metastatic tumor. We all know, too, I'm trying to go through these last slides really quick, but we all know that lung cancer is the largest cause of cancer death. The early stages of lung cancer usually do not have any symptoms, but you may have a persistent cough. You may have a little hemoptysis, meaning coughing up blood. Blood in the sputum can result from the erosion of the blood vessels that are in the lung and growing with the tumor in the lung. So symptoms of this, we're going to have anorexia, weight loss, weakness accompanying the disease. Poor oxygenation of the blood, which will cause, really extreme fatigue, difficulty breathing from the obstructed airway. Diagnosis is obviously a biopsy of the tumor is the definitive diagnosis. We can detect cancer cells in the sputum, and then sometimes you can have washings from the bronchoscopy examination that will detect a carcinoma, but those are not very reliable to go on totally. Treatment is going to be surgery, radiation, chemotherapy. Just depends on the tumor and how it reacts to different treatments. It will metastasize a lot to the GI tract, the female reproductive tract, and the kidneys. Those are the most common. Let's see. Let's go on and talk about infants and children, age-related respiration real quick. With children, we have whooping cough, and that's why they get that DTaP, diphtheria, tetanus, and pertussis, because pertussis is another word, is the medical word for whooping cough. And then usually in children they may have asthma, and they usually outgrow that, so that is very common in childhood to have asthma. With elderly, we may have deterioration of the lung tissue. It may not inflate and deflate properly. So those are most of the problems dealt with the elderly. And I believe that is all for this chapter.